skeletal muscle relaxant is not just limited to produce relaxation whenever there is mild kind of spasm. The use of these skeletal muscle relaxant is very wide. For example, if you see this picture over here, we are trying to intubate the patient. So this is called endotracheal intubation. When a person is not able to breathe, in that circumstances, we have to insert the tube of ventilator inside the patient. So in order to insert those tube against a muscle, you need to first establish muscle relaxation. So the use of skeletal muscle relaxation is to produce endotracheal intubation for any kind of surgical procedure or even to combat some muscle spasm. In dentistry, after extraction of tooth, especially the third molar, the lower mandibular third molar, you tend to develop spasm of the mouth, because of which for a few days due to injury you may not be able to open your mouth and you may not be able to eat also. You might develop trismus also, that is inability to open the mouth because of traumatic injury. So if you are not able to eat anything, then you will not survive. So patients are prescribed muscle relaxant like drugs so that whenever they try to open their mouth, they suffer less pain and it becomes easier for them at the same time. So there are three types of skeletal muscle relaxant. One is called neuromuscular blockers, one are spasmolytic, and then is the antispasmodic. Now in these three different categories, the most important one is the first one, that is neuromuscular blockers. Regarding spasmolytic and antispasmodic, if you just remember the names, it might be enough for now. Now on your right hand side of your slide, you can see different topics that are associated with the skeletal muscle relaxant. Polarizing, and the next one is non-depolarizing. Can anyone tell me what does depolarization mean? What happens in depolarization? No one? Okay, Archana Pariyar.
Yes, sir.
What happens in depolarization?
Sir, polarity automate.
In muscle, what happens if there is depolarization?
Sir, I
Okay,
don't
Asma
know.
Butter, right? Asma,
Yes, sir.
what happens in depolarization? Ashutosh Vandari,
Yes, sir.
what happens in depolarization?
Sodium enters.
Okay, very good. Sodium enters. So basically, when sodium enters, there is contraction. But what we are trying to produce is relaxation. So my question is, how can a drug that produce depolarization produce relaxation instead of contraction? The second category is the non-depolarizing drugs. This makes sense. If you don't depolarize the muscle, it won't contract. But if you see the first category, depolarizing, then a depolarizing drug should produce contraction. If it produces contraction, how is it able to produce relaxation then? So we'll come to that in the later slides. Now, here among the non-depolarizing, we still have further two categories, which are the steroidal and the non-steroidal. From exam point of view, it is not necessary to remember the steroidal or the non-steroidal. If you just remember the names, that will be enough. But why am I dividing it into steroidal and non-steroidal is that steroid has a structure called 4 of the benzene rings. We call it this ring cyclopentano. Hazur.
Sir, slide present भएको छैन.
Now?
Yes, sir. Now it's seen.
Okay. So I was saying that NMB are of two types. One is the depolarizing and the next one is non-depolarizing. Depolarizing, it produces contraction, but our main role is to produce relaxation, although it is producing contraction. The second one is the non-depolarizing. That definitely makes sense. Depolarizing bhaina bhane contraction hune kurai आउँदैन. Non-depolarizing ma pani we have two categories. One is the steroidal and the non-steroidal. Exam point of view, but if you don't remember on this basis, it is easy for you. That why am I focusing on the steroidal and non-steroidal is that when it comes to steroidal, you have this ring ABCD गरेको ring देखाइरहेछ, that is called cyclopentanoperhydrophenanthrene. This ring makes the drug lipid soluble. तर यो ring सँगसँगै there is attachment of this nitrogen group over here. If you see nitrogen, it is plus charge. If you see nitrogen over here, it is plus charge. Similarly over here, it is plus. It is here we are seeing plus charge. This all makes this drug very charged particle, a polar particle. जसले गर्दाखेरि the drugs are not easily able to cross the blood-brain barrier. It tends to remain in the circulation only. Now we move on to the next section, that is normal function. For the muscle to contract, two molecules of acetylcholine has to bind to the NM receptor, which is going to open the channel and sodium is going to move inside. That is how depolarization takes place. Now, if you see the molecule named succinylcholine, it is actually a combination of two molecules of acetylcholine. दुईटा molecule of acetylcholine लाई combine गरेर बन्ने molecule को नाम हो succinylcholine. That is why succinylcholine is able to produce depolarization. तपाईको exam को viva question एउटा name one depolarizing NMB neuromuscular blocker हुन सक्छ, because there is only one. Now, because all of the neuromuscular blockers are charged particles, whether you talk about the succinylcholine, here we have 1 plus charge, here we have 1 plus charge, or you talk about the other non-depolarizing, all of them they have plus charge. which makes this drug more of charged, non-lipid soluble. So they cannot cross blood-brain barrier and it cannot produce any action on the brain. Although we do not want action also, and brain does not have skeletal muscle also. So basically it is so charged that it cannot cross blood-brain barrier, it cannot cross placental barrier also. And because of this thing, you cannot give this drug via oral route also. You have to give this drug via parenteral route. मुखबाट खायो भने पनि they are not easily going to get absorbed. Now, if you come to the pharmacokinetic parameters of this drug, since this drug is charged particle, it has to be eliminated basically by the kidneys, but it does undergo some kind of metabolism in the liver. If you see this diagram over here, the NMB which are excreted via the kidneys, they have longer half-life, whereas those that are excreted both by the liver and kidneys, they have shorter half-lives. Which makes this drug shorter acting. Few are shorter acting, some are intermediate acting like vicuronium and rocuronium, whereas some are longer acting like pancuronium. So vicuronium and rocuronium are intermediate acting because they have shorter half-lives. Now, among the non-depolarizing, we have one drug that is called etracurium, which is no longer used clinically. Hospital practice में use हुँदैन, तर तैपनि हामी पढ्छौं. किन पढ्छौं? Because of two things. One is, it is among those few drugs that undergo spontaneous metabolism. न त त्यो किडनीबाट एलिमिनेट हुन्छ, न त त्यो लिभरबाट नै मेटाबोलाइज हुन्छ, त्यो प्लाज्मामा आफै डिग्रेड हुन्छ. अनि त्यस्तो टाइप अफ डिग्रेडेसनलाई भन्छ हफम्यान एलिमिनेसन. केरी त्रिपाठीमा पनि जेनरल फार्माकोलोजीमा एकदम सानो मसिनो अक्षरमा हफम्यान एलिमिनेसन लेखेको छ. अनि सानो मसिनो अक्षरमा लेखेको नै फेरि भाइभामा सोध्ने गर्छ. अनि when this drug undergoes metabolism, this forms a compound known as laudanosine, which can produce seizure in patient. So we need to remember etracurium because of two things. It undergo metabolism by Hoffman elimination, and the metabolite that is formed can produce seizure. यो हस्पिटलमा युज हुँदैन भने कुन चाहिँ युज हुन्छ त? देन we have cis etracurium that has completely replaced the etracurium. It does not form the metabolite laudanosine, because of which it is not able to produce seizure in patient. त्यो त भयो नन डिपोलराइजिङ को. तर डिपोलराइजिङ मा पनि जुन एउटा मोस्ट प्रोबेबली थ्योरी एज वेल एज भाइवा एस्पेक्टबाट सोध्ने क्वेशन भनेको सक्सिनाइल कोलिन हो. फ्रम इट्स फार्माकोकाइनेटिक प्यारामिटर्सबाट भन्नुस्, यसको क्लिनिकल युज भन्नुस्, अर इट्स एडभर्स इफेक्ट, तीनटैबाट सक्सिनाइल कोलिन इज इक्वली इम्पोर्टेन्ट. अब दिस इज शर्टर एक्टिङ. यसको धेरै लामो टाइमसम्म काम गर्दैन because of two things. One is it undergoes rapid hydrolysis. Hydrolysis पनि दुईटा पार्टमा हुन्छ, in the plasma and in the liver. प्लाज्मामा गराउने स्युरोकोलिनिस्टरेज, लिभरमा गराउने ब्युटारिल कोलिनिस्टरेज. अब स्युरोकोलिनिस्टरेज हुने बित्तिकै it depends upon the genetics of the person. उसले यो ड्रगलाई चाँडै मेटाबोलाइज गर्छ कि ढिलो मेटाबोलाइज गर्छ. त्यो मान्छेको pseudocholinesterase normal छ कि it is some defect in that. जसको मा डिफेक्ट छ उसको मसल prolonged time सम्म रिल्याक्स भइदिन्छ. He may not be able to breathe if he is given succinylcholine. भन्न खोजेको त्यो हो. And once succinylcholine reaches the muscle end plate, it is supposed to produce relaxation, which it will also, despite it is depolarizing. Tara, for this effect of the succinylcholine to go away, it has to be washed away from the muscle plate to the plasma. In the synaptic cleft, we do not have the enzymes that is going to break down succinylcholine. The enzyme that will break down succinylcholine, it is either present in the liver or it is present in the plasma. It is not present in the synaptic cleft. Now, there is, like I said before, there is some abnormality in few people, not everyone, few people, just saying there is some kind of defect in the pseudocholinesterase. Now, basically what happens is that if we talk about first the non-depolarizing, duita molecule of acetylcholine will bind to the NM receptor. It is going to activate the receptor and the sodium is going to move in. Now, if I want to block this receptor, how many blockers do I need? 1 or 2? Can anyone tell me? अनुजा मल्ल ठकुरी.
Yes, sir.
कतिवटा ब्लकर चाहिन्छ? Can you still see the slides?
Okay.
Okay. दुईटा एसिटाइलकोलिन मोलिक्युलले एनएम रिसेप्टरलाई ओपन गरिरहेछ भने इफ यु वान्ट टु ब्लक दिस एउटा मात्रैलाई ठाउँमा ब्लक गरेको छ, दुईटा ब्लक गर्नै पर्दैन. दुईटा चाबीले यो लक खोल्ने हो भने एउटा चाबी मात्रै भएन भने त्यो लक खुल्नेवाला छैन. So the non-depolarizing ones, they are going to act on the NM receptor and it is going to compete with the acetylcholine. Competition with acetylcholine means if you want to reverse this, you can increase the number of acetylcholine molecule at the same time. Acetylcholine molecule concentration तपाईले बढाइदिनु भयो भने it can displace the non-depolarizing neuromuscular blockers. जस्तै कि for example यहाँ हेर्नुस्, lots of acetylcholine molecules are here. It is going to be degraded by acetylcholine esterase. That if you give anti-acetylcholine esterase molecule, all the acetylcholine molecule concentration is going to increase, which can displace the neuromuscular blockers, which are non-depolarizing. So non-depolarizing neuromuscular blockers can be reversed. एउटा क्वेशन जुन एक्जाममा सोध्न सकिने हो, what is the difference between a depolarizing and a non-depolarizing भनेर आउँछ. एउटा डिफरेन्स, फर्स्ट डिफरेन्स भनेको non-depolarizing are reversible and depolarizing are not reversible. Then we move to the next section, that is the depolarizing. नामले नै के भन्छ, इट इज गोइङ टु डिपोलराइज. डिपोलराइज हुने बित्तिकै त्यो मसल त कन्ट्र्याक्ट हुनुपर्छ, तर हामीलाई चाहिएको छ रिल्याक्सेसन. अब के हुन्छ भन्दाखेरि चाहिँ डिपोलराइजिङमा वी क्यान फर्दर क्लास सबडिभाइड इन्टु फेज 1 एन्ड फेज 2. फेज 1 मा वी हेभ द डिपोलराइजिङ इटसेल्फ एन्ड फेज 2 मा हुन्छ डिसेन्सिटाइजेसन. भन्नाले इफ यु गिभ दिस सक्सिनाइलकोलिन मोलिक्युल टु द पेशेन्ट, फर्स्ट त यसले एनएम रिसेप्टरलाई नै एक्टिभेट गर्छ. न्यूरोमस्कुलर रिसेप्टरलाई एक्टिभेट गरिसकेपछि फर्स्ट देयर इज गोइङ टु बी डिपोलराइजेसन. डिपोलराइजेसन भएपछि चाहिँ इनिशियली देयर इज गोइङ टु बी मसल कन्ट्र्याक्सन. तर त्यो मसल यति डिपोलराइज भएर बस्दिन्छ द्याट सक्सिनाइलकोलिन मोलिक्युललाई वाश नभएकोले, सक्सिनाइलकोलिन मोलिक्युललाई त्यसको एक्सनलाई टर्मिनेट गर्न नसकेकोले त्यो मसल डिपोलराइज फर अ लङ पिरियड अफ टाइम हुन्छ, जसले गर्दाखेरि इट बिकम्स अनरेस्पोन्सिभ. जस्तै कि मैले क्लास सुरु गरेँ 9:30 मा, मैले 10:30 सम्म पनि पढाएँ, त्यसपछि 11 बजेसम्म पनि पढाएँ, त्यसपछि 11:15 सम्म पनि लियो भने यु विल स्टप लिसनिङ टु मी. Some of you might be not listening at all. That is because you have become desensitized. सुरुको 5 मिनेट दिमागमा छिर्यो, त्यसपछि के पनि छिरेन. That is, you become desensitized. Similarly, यहाँ पनि त्यही नै हुन्छ. If I give succinylcholine molecule, it is going to depolarize. तर because succinylcholine molecule has not been replaced, त्यो muscle contraction जुन छ त्यो prolong भएर it starts to become desensitized. त्यसलाई हामी भन्छौँ फेज 1 ब्लक. त्यो बेलामा इभन इफ यु इन्क्रिज द कन्सन्ट्रेसन अफ एसिटाइलकोलिन मोलिक्युल इट क्यान नट बी रिभर्स्ड. तर फेज 2 मा चाहिँ देयर इज सम चान्सेस अफ रिभर्सिबिलिटी. तर हुनै पर्छ भने चाहिँ देयर इज सम चान्स अफ रिभर्सिबिलिटी. फेज 2 नाम किन राखेको भन्दाखेरि even if that muscle is depolarized for a prolonged period of time, automatically the muscle will become repolarized, tada it will stop responding. मैले अहिले तपाईलाई क्वेशन सोध्यो भने यस सर चाहिँ भन्नुहुन्छ, त्यसपछि सोधे गर्यो भने त्यसपछि you will even stop saying yes sir. के सोध्छ भन्नु. So that is another stage that is called desensitization. त्यसपछि response चाहिँ आउन छोड्छ. तर त्यो बेलामा चाहिँ if you are able to increase the concentration of acetylcholine, it can produce contraction. भन्ने मात्रै हो, तर it's not sure. So basically जो non depolarizing छ they are reversible, जुन depolarizing छ they are non reversible. So we say there is only a possibility of reversal, not sure. अब किन दिने त स्केलेटल मसल रिल्याक्सेन्ट? जीए मात्रै दिएर हुँदैन, नाइट्रस अक्साइड, अक्सिजन त्यत्रो धेरै जेनरल एनेस्थेटिकहरू छ, त्यत्रो ड्रग मध्ये एउटा ड्रग दिएर मसल रिल्याक्सेसन प्रोड्युस गर्न सक्दैनौँ त हामीले. किन यो छुट्टै ड्रग दिनु पर्यो? त्यसको रिजन के छ भन्दाखेरि चाहिँ इफ यु गिभ हाई कन्सन्ट्रेसन अफ जीए, एउटा त पेशेन्टको कस्ट बढ्नेवाला छ, तर एट द सेम टाइम पेशेन्टलाई एडभर्स इफेक्ट पनि बढी हुन्छ. 5 mg चाहिने ठाउँमा 50 mg दिनुपर्ने हुन्छ. स्केलेटल मसल रिल्याक्सेसन पनि प्रोड्युस गर्नु पर्यो भने त्योभन्दा बरु 5 mg पनि दिने, अर्को 5 mg को मसल रिल्याक्सेन्ट सँगसँगै दियो भने इट क्यान प्रोड्युस इक्वल एफिसिएन्सी. त्यस कारणले वी नीड टु गिभ स्केलेटल मसल रिल्याक्सेन्ट अलङ विथ जेनरल एनेस्थेटिक्स. अब मसल रिल्याक्सेसन कसरी प्रोड्युस हुन्छ त? सबैभन्दा सुरुमा स्मल मसल्सहरू रिल्याक्स हुँदै गर्छ, लास्टमा चाहिँ ठुलो मसल द्याट इज द डायफ्राम रिल्याक्स हुन्छ. भनेपछि सबै मसल रिल्याक्स भइसकेपछि मात्रै तपाईको रेस्पिरेटरी मसल रिल्याक्स हुन्छ. अनि when you withdraw the muscle relaxant, first muscle to recover will be the diaphragm. तपाईको सास लिने मसल will recover. अनि लास्टमा चाहिँ स्मल मसल्स भन्दाखेरि तपाईले स्केलेटल मसल रिल्याक्सेन्ट विथड्र गर्नुभयो, विथड्र गरिसकेपछि लास्टमा तपाईको if the patient has started to blink his eyes, उसले चलाउन सक्यो भने चाहिँ you have to understand that उसको small muscle हरु already strength gain गरिसक्यो. Now this patient can breathe on his own भनेर. किनभने यदि सानो muscle recover भइसकेको छ भने चाहिँ diaphragm has already नन डिपोलराइजिङ मा तपाईको एकदम शॉर्ट एक्टिङ भनेको तपाईको 6 रोक्युरोनियम हो जसको टाइम ड्युरेसन 60 to 120 seconds छ, which is even shorter than the succinate choline. Now these relaxant has its own adverse effect. अब यसको adverse effect को कुरा गर्ने हो भने mostly they release histamine. Histamine can produce bronchospasm, it can produce tachycardia due to vasodilation. तर at the same time एउटा सक्सिनाल कोलिन भन्ने जुन डिपोलराइजिङ छ त्यसले चाहिँ तपाईको चाहिँ malignant hyperthermia गराउँछ. अनि यो malignant hyperthermia भनेको most frequently asked MCQ question पनि हो. Which muscle relaxant produce malignant hyperthermia भनेर. Plus this succinylcholine molecule should not be given if the patient has burn injuries, if there is nerve damage, head injuries. किन भन्दाखेरि चाहिँ त्यस्तो केसमा चाहिँ it can produce hyperkalemia that can produce cardiac arrest. Patient collapse हुन सक्छ. त्यो सँगसँगै it also tends to increase some of the pressure inside the body like intraocular pressure, gastric content को pressure हरु यसले बढाइदिन्छ. तर बिर्सिनै नहुने भनेको चाहिँ malignant hyperthermia. Succinylcholine ले directly malignant hyperthermia गराउँदैन. It is basically seen when you give halothane as inhaled anesthetic. त्यस्तो बेलामा चाहिँ malignant hyperthermia हुन्छ. अनि त्यो malignant hyperthermia लाई म्यानेज गर्नलाई तपाईले चाहिँ एउटा अर्कै skeletal muscle relaxant दिनुपर्छ जुन चाहिँ dantrolene हो. Now muscle relaxant तपाईले produce गर्नुभयो by giving a non-depolarizing. Now if you want to reverse it, reverse गर्नलाई you will increase the concentration of acetylcholine. Acetylcholine को concentration बढाउनलाई you will give acetylcholine esterase. That is going to increase the concentration of acetylcholine. त्यसको लागि हामी neostigmine र physostigmine prefer गर्छौं. Sorry, neostigmine and pyridostigmine हामी prefer गर्छौं. तर we do not prefer physostigmine. Why? अर्पणा कार्की
हजुर सर.
किन होला? Reversal को लागि we give neostigmine and pyridostigmine, but we do not give physostigmine because skeletal muscle are not present in the brain. And physostigmine भन्ने drug, it can cross blood-brain barrier. Neostigmine and pyridostigmine, they do not cross blood-brain barrier. त्यो भएकोले. Now coming to the uses of neuromuscular blockers, we have for the purpose of muscle relaxation during surgery, endotracheal intubation को लागि पनि we are using. For easy ventilation, corona को बेलामा patient लाई ventilator मा राख्दाखेरि पनि we have to give skeletal muscle relaxant. convulsions, epilepsy, seizures control गर्नलाई पनि you have to give neuromuscular blockers. So that ends with the first class of muscle relaxant, that is the neuromuscular blockers. Then we have spasmolytic and antispasmodic. Our spasmolytic basically they are used in case of any kind of injury, bike accident या कुनै car road accident मा चाहिँ upper motor neuron lesions हरु भयो, spinal cord injury भयो भने चाहिँ in that case you have to go for spasmolytic. तर कुनै heavy सामान बोक्दाखेरि muscle spasm भयो भने चाहिँ you have to go for antispasmodic drugs. अब spasmolytic basically upper motor neuron भनेको spinal cord injury, cerebral palsy, multiple sclerosis अनि brain injury, stroke हरु भयो भने चाहिँ त्यस्तोमा दिने भयो. For example तपाईको spasmolytic मा diazepam, midazolam हरु हुन्छ. यो खाइसकेपछि patient is very much dizzy, drowsiness. He has to stay in bed. उले कुनै पनि attention seeking work हरु गर्न सक्दैन. Driving हरु त possibly हुँदैन. So only in those upper neuron lesions you have to give drugs like diazepam and midazolam. Plus तपाईसँग अरु drugs हरु पनि छ like baclofen. Baclofen हरु पनि दिन सकिन्छ, which is GABA B agonist. यसले पनि तपाईको muscle relaxant produce गर्छ. त्यसपछि tizanidine छ, which is alpha 2 agonist. अनि एउटा dantrolene, अघि हामीले जुन malignant hypothermia को बेलामा भनेको थियो त्यो dantrolene पनि तपाईको यसैमा पर्छ. Now among the antispasmodic यो चाहिँ फेरि spinal cord injury या cerebral palsy मा चाहिँ यो युज इफेक्टिभ हुँदैन. यो चाहिँ बेसिकली तपाईको चाहिँ लोकल मसल स्पाजम लाई मात्रै युज हुन्छ. ढाड दुख्यो, सडन मसल स्पाजमहरु भयो भने मात्रै तपाईको एन्टिस्पाजमोटिक्स आर इफेक्टिभ. यानी यसमा चाहिँ तपाईको ड्रग्सहरु छ प्रोर्जोक्साजोन, कार आइसोप्रोडोल, क्लोरफेनिसिन, साइक्लोबेन्जाप्रिन. र यो ड्रग्सहरुमा चाहिँ मोस्ट कमनली युज हुने ड्रग भनेको प्रोर्जोक्साजोन. डेन्टिस्ट्रीमा पनि तपाईको चाहिँ कुनै थर्ड मोलर एक्सट्र्याक्सन पछि चाहिँ पेशेन्टलाई चाहिँ मसल स्पाजम भयो भने दिने भनेको प्रोर्जोक्साजोन. तर इफ प्रोर्जोक्साजोन इज नट इफेक्टिभ त्यस्तो कन्डिसनमा चाहिँ ब्याक्लोफेनहरु पनि दिइन्छ. With this we finish. तर यो सिद्धियो भन्दैमा चाहिँ I'm not going to end it. I will still ask few questions. लास्ट बाट सुरु गरौँ ल. पेमा लामा.
Yes, sir.
के बुझ्नु भयो?
Sorry about the skeletal muscle.
त्यसमा के बुझ्नु भयो? स्केलेटल मसल रिल्याक्सेन्ट तीनटा क्याटेगोरीको छ. एउटा न्यूरोमस्कुलर ब्लकर हो, एउटा स्पाज्मोलाइटिक अनि एउटा एन्टिस्पाज्मोटिक. रिया उपाध्याय.
Yes, sir.
डेन्टलमा युज हुने मसल रिल्याक्सेन्टको नाम एउटा भन्नुहुन्छ?
Delma, sir. Chlorzoxazone.
Very good. Chlorzoxazone used हुन्छ. जेनिसा साक्य. भाग्यो. जेनिसा साक्य. जिन्नत बनो.
Yes, sir.
हाम्रो जुन